Phase 1 Ebola mHealth Project for Community Health Workers. The current Ebola epidemic in West Africa is unprecedented in size and scope and has not yet been brought under control in the countries of Liberia, Sierra Leone, and Guinea, although there has been significant progress. In Sierra Leone, in November, they saw the highest rate of new infections. West Africa suffers from a severe shortage of trained medical personnel. In some of the affected areas, one physician serves an area of 10,000 people, and equipment and medicine for treatment is not universally available. Community health workers are often the only access to health care and information available to people living in rural areas and impoverished urban areas. Whereas doctors, nurses, and health infrastructure may be sparse in West Africa, mobile phones are not. Mobile technology can increase the capacity of local health workers and empower them with information and skills. This ability of mobile technology to increase the capacity of health workers has been referred to as task shifting, as technology can increase the reach and scope of what a health worker can do, allowing them to perform tasks formerly reserved for more highly trained personnel. The problem in West Africa comes down to determining who has been exposed, rapid diagnosis so that infected people can get into treatment quickly, and getting communities organized and educated so that people are willing to isolate and practice proper burial and hygiene techniques around those who are ill. The big picture goal is to get Ebola sufferers into treatment more quickly, which has been shown to improve survival rates, and to lower the reproduction number, that is, the number of people infected by a case, to below 1. The measurable objectives of the mHealth project are to demonstrate that users of the system show increases in adherence to isolation, hygienic, and burial practices in their communities, show decreases in time between diagnosis and treatment for individuals, show initial increases in the number of new cases identified, and show decreases in the number of family members infected for each Ebola case. The Ebola mHealth Project for Community Health Workers has a number of different components grouped under surveillance, diagnostics, and education activities. Surveillance involves information to the community health workers as well as organization and documentation tools for them, and then getting the information they gather out to the wider health community. The first aspect would be letting community health workers know when there is Ebola-related activity in their area, so they can better direct their efforts. In Liberia and Guinea, the state has set up an Ebola hotline. The CDC has been geo-tracking the calls to the hotline by the nearest cell phone tower where they were placed. With our program, when there's an uptick in activity in a particular location, the community health worker responsible for that locality would be alerted via text so that he or she can make inquiries and increase visits to the area. Secondly, managing surveillance is very complex for a disease like Ebola, where contacts can be many and where follow-up for contacts lasts for 21 days. In Nigeria, to successfully stop the epidemic of 20 Ebola cases, 900 people received 18,000 healthcare visits. A step-by-step tool like the Ebola Management Cascade, which outlines how to group people and record cases, can be used on smartphones and developed for SMS as well. In diagnostics, the project would provide community health workers with detailed and updated outlines of symptoms to look for in Ebola surveillance and questions to ask potential patients. There will be a hotline where community health workers can text in a question and get a quick response from a physician or nurse. Community health workers will receive regular updates of the nearest health centers and labs and their current capacity so they can redirect people if one place gets backed up. They will be informed of lab results for contact tracing. The health behavior education part of the project will have 2 components. The first will be providing accurate information to the community health worker to keep him or herself safe and confident and up to date on local services available. The second will be providing the community health worker with tools and methods via messaging for communicating with communities to reduce fear, to improve attitudes towards testing and quarantine, and increasing self-efficacy of basic infection control measures, including burial. The Ebola mHealth Project for Community Health Workers is innovative in that it brings together a number of affordances of mobile digital technology. It allows task shifting through the diagnostic algorithm and updated information. It weeds down and localizes existing information so that it is actionable by the local community health worker. And local surveillance information is stored, aggregated, accessible, and geotagged so resources can be best allocated. Most importantly, it uses the synergy of human and digital technology. We will initially recruit community health workers that have worked with smartphones in other mHealth capacities for the quickest deployment of the project. But with proper education protocols and resources for smartphones, this project could scale for greater reach through partnering with NGOs already working with community health workers in West Africa. As the epidemic comes under control, the project could be adapted to include surveillance, diagnosis, and education regarding other endemic diseases like malaria and even non-communicable diseases like hypertension and diabetes as resources for Ebola move to other uses. Thank you.